Gotta keep the pump. Gotta keep the pump. You guys may have seen my movie. That's me without my shirt on. Real quickly, let's talk about the case. Let's talk about the history. A couple salient features jumped out at me. She's got shortness of breath, chest pain, right-sided. She's got fullness, swelling, and pain somewhere in this area, maybe a little bit of the armpit. Subjective fevers. It's been going on for 2 weeks. I'm actually short of breath right now. It's been going on for 2 weeks. She's not doing this subacutish. She's got a history of lupus. She's on prednisone and hydroxychloroquine / plaquenil. Okay, so that history, forced me to generate a few questions. Is this related to a lupus flare? Is this related to a complication of lupus? Is this related to our medications, the hydroxychloroquine, the plaquenil, the prednisone? Is this new, or is this an exacerbation of something chronic? Will this kill her now, or will this kill her later? And lastly, why did I sign up for this? So this is my initial differential diagnosis, solely based off of my history. 4 main problems, what I identified. Shortness of breath, chest pain, fullness, swelling, this sitch, subjective fevers. Huge differential. I'm immediately intimidated, as if I just got sucker punched in my face. I got the main killers: acute pulmonary embolism, acute aortic dissection. I got the great mimickers: tuberculosis, lymphoma, lymphadenitis, Lemierre's phlebitis, venous thromboembolism, endocarditis. It's got to be endocarditis. And why'd you have to give me lupus? All right, maybe the time course could help me. Maybe the time course could help. So we're going on for 2 weeks. Got a little bit worse in the past 2 days. All right, shows up at county. I think this was a county. Maybe I could split it up. Maybe on the time course could help. Maybe I could focus on the things that showed up acutely. Split it up versus those things that were more subacute, things that take a little while to develop. So let me split it up. Maybe make a list. The acute, PE, acute coronary syndrome, acute aortic dissection. Those happens really quick. They get acute shortness of breath, acute chest pain. They're coming in right away, brought in by EMS. Versus the subacute, maybe a PE, pericardial effusion, maybe a deep neck space infection, some sort of lymphoma, neoplastic, something. It's been going on for 2 weeks. I'm leaning more towards that side of my differential. Okay, sounds good. How about the physical exam? I have no idea what's going on here. Let's look at those vitals. Tachycardia, I'm assuming it's sinus tach. You know the differential is going to be like 1,000 different things. Blood pressure is pretty high, she's hypertensive. Is that because of her tachycardia? Is that because she's uncomfortable, she's in pain? Afebrile, sad and well. She looks comfortable, she's not in acute distress. She's AO times 3, normal cranial nerves. She's got this thing going on in her neck and her armpit. I have no idea what that is. She's tachycardic, no abnormal or extra heart sounds, which to me is screaming pertinent negatives. Cleared auscultation. Belly soft, non-tender. That just throws me for a loop. I feel immediately defeated by this case. I don't know what's going on here. Okay, but I got a great support system. I got Dr. Beyda, I got Dr. Lee, and that's me. You know what I look like without my shirt on. Okay, I need to just regroup, concentrate, focus. All right, what system is this? I got the neck thing, I got the chest pain, I got the shortness of breath, there's something going on here, she's got lupus. Okay, all right, I gotta connect the dots, All right, is it the arterial system? I mean, that could explain something going on in the neck, the supraclavicular fossa, the axillary, that continues, and the chest. I mean, is this like a dissection? Is this a vascular aneurysm? What's going on? Is this the lymphatic system? She's got lupus, she's on steroids, she's at risk for autoimmune complications, lymphoma, lymphadenitis, she's on prednisone. She's got the neck, the supraclavicular fossa, the axillary lymph nodes, the chest pain. Okay, could be that, What about the venous system? Okay, I'm pumped right now. All right, neck, supraclavicular fossa, axillary, and chest pain. Okay, so they all fit, so now I'm really confused. All right, I'm confused. But I know I need to summarize my case. There's summary number 1. 30-year-old female, she's got lupus, she's on steroids, we know that. She's got subjective fevers, she's got shortness of breath, chest pain, subacute, 2 weeks. This axillary, left cervical, left supraclavicular fullness. Her exam, she's not in acute distress, but she's tachycardic, she's hypertensive, and she's got this inflammatory itis type situation going on in this area. Okay, all right, clarifies a little bit for me. I got my history, I got my physical. Let me try and narrow down, just based off of my history and physical, my differential. Now I'm coming out slugging. All right, bam! Woo! Pumped. My confidence went up from here to just about here. So I'm really not confident about this case. But I don't think she's got spontaneous pneumothorax. It just doesn't present with inflammation of the left neck. I don't think she's got a myocardial ischemia, acute coronary syndrome. It just doesn't present with that. I don't think she's got a pneumonia. It's not primarily that explains this. I don't think she's got a skin and soft tissue infection only here that explains the shortness of breath, chest pain. I don't think she's got obstructive lung disease, COPD, asthma exacerbation. It just doesn't go with this story. I still got a few other things up there though. All right, maybe some labs. Let's take a look at those labs. I got a CPC, okay. Now, that's what was given to me. Got the comprehensive. Got a troponin, she's got chest pain, got worse over the past 2 days, certainly possible, she's at risk. Got this BNP. I see a normocytic anemia, okay. I see lymphopenia on the CPC. All right, comprehensive was pretty unremarkable. And the BNP was a little bit high. Okay, what's going on here? Come on guys, what'd you guys do? Normocytic anemia, lymphopenia. I mean, I think that's chronic. I think she's got lupus. I think that's just coming with her. She's packaged. The BNP elevation, chest pain, shortness of breath, I think that's acute. But I gotta tell you, I'm getting my butt kicked right now. I have no idea what's going on. What's a differential for a BNP elevation? Well, if I put it in the context of my history and physical, I can eliminate a lot of these things. I still got acute pulmonary embolism though, some sort of infectious process. There's a few other things up there. But I don't think she's got coronary artery disease or myocardial trauma, so I can pretty much rule those out. All right, and I have those things on my initial differential. Let me summarize it one more time. Lupus, 30 years old, steroids, Plaquenil. Shortness of breath, chest pain, 2 weeks. She's got this fullness situation going on here, subjective fevers. Her exam, tachycardic hypertensive. This inflammation, itis type of stitch going on here. And she's got an acute BNP elevation. All right, okay. Imaging, right? Chest pain, shortness of breath. I mean, this is going to give it away. This is going to tell me what's going on right now. I get a PA chest x-ray. That's all I get. Why? I'm telling you, I've never looked at an x-ray in my life. Like I have looked at this x-ray. Knowing that I will stand here in front of my colleagues judging me. Seeing that I'm actually dyspneic on exertion from walking there to there. This is pathetic. And no, I don't have a six-pack. All right, so it's PA. I'm so intimidated by this chest x-ray right now. But if I place it, compare it next to what I think should be a normal female chest x-ray, PA frontal, you can start to maybe point out some things that jumped out to me. And maybe I'm being super sensitive. It's not rotated, it's adequately exposed, but I have to admit there's one limitation that I identify in this chest x-ray, and that is maybe not ideally fully inspiratory. So maybe there's a rib or two short. Okay, so maybe some of my findings are going to be limited, but what's that? I mean, that just looks a little bit wide to me compared to what I think is normal. An apical pleural cap, is that some sort of fluid, a large vein, a large vessel? I don't know. I see blunting of the left costophrenic angle. In this context, I'm thinking this is a pleural effusion. I mean, Stein looks a little bit wide to me. I mean, I have to admit, I looked at this long and hard, and compared to that, it looks a little bit wide. But that could be a limitation of my poor inspiratory chest x-ray, possible. That trachea, maybe deviated, maybe not. Maybe there's something pushing it, I don't know. Cardiomegaly, possible, but again, if it's not fully inspiratory, I don't know. There's this left paravertebral line, I'm telling you, I went deep into this x-ray. That's associated with mediastinal pathology, so I mean, how does that fit here? I'm not sure, but it's not on this one, and it's definitely not normal. All right, I think the azygous vein, we should do that one more time, just because I think that's cool, and that took me like an hour to figure out how to do that. I think the azygous vein is dilated. That's just me. But when I look at that one, it's bigger than that one. Okay, cool, cool. All right, that area, just lateral on the left side to the trachea, looks a little bit wide. I know this aortic knobs, the pulmonary trunk. I'm not sure, it just looks a little bit wide to me. It just definitely does not look like the normal. I mean, look at the difference. It doesn't look normal. Right heart border looks a little bit deviated to the right. I don't know. This is like a right heart strain pattern. I don't know if this is poor inspiration. And then there was this one other finding that finally clicked for me, at least for me. And that's this thing right there. Now when I compared the two sides, the right side to me looked like there was peripheral hyperlucency with decreased vascular flow compared to the left side. Now, I don't know if you guys know the name of this sign, but this is what I thought it was. I hope I'm right. I thought this was a Westermark sign. This has the highest positive predictive value for something that I think is going on in this patient. Now, again, not a radiologist who stared long and hard at this, but that side just looks blacker than that side. There's less pulmonary vascular markings. It's peripheral, it's focal, so I'm calling that focal oligemia in the setting of somebody who's hypercoagulable with chest pain, shortness of breath that's subacute. Just saying. Okay? Just saying. That pleural effusion, I already think I'm going to put my money that's exudative. Why? She doesn't have heart failure, she doesn't have liver failure, she's not a cirrhotic, she's not nephrotic syndrome, her comp is unremarkable. So now I've got a radiographic differential to deal with, based off the findings of my chest X-ray interpretation, if I'm right or wrong. Apical pleural cap, maybe some whiting, is this vascular congestion, is this fluid, is this lymphoma? I think it's an exudate, I'm pretty sure I would put money on that. Widen mediastinum, I mean, you know where I'm going with this. It's more than just the SVC. Is the aorta involved? Does she have an ascending thoracic aortic aneurysm? Is there a mediastinal lymphoma? What's going on here? Dilated azygos? Some sort of congestion, high pressures. And there's my exudative pleural effusion differential. All right, so you know I'm thinking about these two things right now. These are the top two of my list. Is this patient, a 30-year-old female with lupus, presenting with subacute chest pain, shortness of breath, have this inflammatory situation going on here, tachycardic hypertensive? Does she have an ascending thoracic aortic aneurysm with or without a dissection, or does she have a pulmonary embolism? Now, last time I checked, and I looked long and hard, they're both kind of great mimickers. So now I'm in serious trouble. But I don't think aortic dissection presents with tender, warmth, erythema, inflammatory signs on physical exam. Okay, so I'm going to do what every radiologist says I should do. I'm going to correlate clinically. I'm going to place this chest X-ray in the context of my labs and my history and physical. I'm fighting back now. This feels so good. I'm going to get this wrong. Putting it all together. Don't take my word for this. I put my history, my physical, my labs, my imaging. Summarize number 3, mainly because my confidence is not as high as I'm portraying it. 30-year-old female, chest pain, shortness of breath, lupus, steroids, hypertensive tachycardic, subacute fevers, subjective fevers, chest pain, shortness of breath, SITch, BNP elevation, acute, wide mediastinum. I think there's focal oligemia, left pleural effusion, which I'm committing. I'm putting my money down. It's exudative. I think that this patient had a venous thromboembolism. Oh, she's looking at me like I'm wrong. Venous thromboembolism, intersubclavian, internal jugular vein, upper extremity vasculature that embolized her to her pulmonary vasculature. Why do I think this? Lupus is a hypercoagulable state. It's well documented in the literature that these patients get DVTs, lower extremities, upper extremities. Documented, well known. Also, what about this wide mediastinum? Case report this year, MIMO, patient presented with chest pain, wide mediastinum, had an acute PE as the diagnosis. Okay, so maybe I'm a little bit more comfortable with accepting that the wide mediastinum doesn't exclude PE. But also, aortic aneurysms in lupus patients, meta-analysis, 35 cases in the literature, over 40 years. So my pretest probability for aortic dissection versus acute pulmonary embolism, PE is up here, aortic dissection or aneurysm is here. Also, IJ DVTs can embolize in 5 to 25% from some papers that I've found, and can present with symptomatic PE. So I'm feeling confident. I'm feeling confident. My most likely diagnosis is acute submassive pulmonary embolism. So what do I do next? Do I do an echo? Do I do a chest CT? Do I do a VQ scan? Do I do an MR? My next test is, in reality, if this patient was in front of me, would be to take a bedside sono, place a probe on her neck, suprasternal, do an echo, see if there's widened or dilated aortic root, see if there's an intimal flap, or to see if there's evidence of right heart strain, or to see if I can find any DVT or thrombus in the left IJ. But if I want to make a definitive diagnosis, I would want a CT pulmonary angio. Do I show up victorious, or do I have to give up my champion's belt? Thank you.